Greetings everyone, and welcome to the Cardiology Podcast, Why We Do What We Do in Cardiology. In this audio series, we will be discussing the practice-changing articles in the field of cardiology, from the past to the present. This is your episode for today.
Today I will discuss a review paper titled Comparison of Initial Antithrombotic Regimens After Left Atrial Appendage Occlusion, a Systematic Review and Network Meta-Analysis. Brazilian authors, including Pedro Carvalho, wrote this paper. This was published in the Journal of the American College of Cardiology in August 2023. Background: the optimal antithrombotic therapy following left atrial appendage occlusion, LAAO, in patients with non-valvular atrial fibrillation, AF, is not yet known. Objectives: this study compared the efficacy and safety of various antithrombotic strategies after LAAO. Methods: the authors searched Medline, Cochrane, Embase, Lilacs, and clinicaltrials.gov databases for studies reporting outcomes after LAAO, stratified by antithrombotic therapy prescribed at post-procedural discharge. They analyzed direct oral anticoagulants, DOACs, vitamin K antagonists, VKAs, single antiplatelet therapy, SAPT, dual antiplatelet therapy, DAPT, DOAC plus SAPT, VKA plus SAPT, and no antithrombotic therapy. They used a frequentist random effects model network meta-analysis to estimate the odds ratio, or, with 95% confidence intervals, CI, for each comparison. The p-scores provided a ranking of treatments. Results: 41 studies comprising 12,451 patients with non-valvular AF were included. DAPT, DOAC, DOAC plus SAPT, and VKA were significantly superior to no therapy to prevent device-related thrombosis. DOAC was associated with lower all-cause mortality relative to VKA, or 0.39, 95% CI 0.17 to 0.89, p equals 0.03. Compared with SAPT, DAPT was associated with fewer thromboembolic events, or 0.50, 95% CI 0.29 to 0.88, p equals 0.02, without a difference in major bleeding. In the p-score analysis, DOAC monotherapy was the strategy most likely to have lower thromboembolic events and major bleeding. Conclusions: this network meta-analysis found that DOAC monotherapy had the highest likelihood of lower thromboembolic events and major bleeding after LAAO. DAPT was associated with a lower incidence of thromboembolic events than SAPT and may be a preferred option in patients unable to tolerate anticoagulation. Summary: the treatment for patients with non-valvular AF undergoing LAAO has evolved. Initially, VKA therapy was used, but more recent studies have shown that DOAC therapy, DAPT, and SAPT can also be effective. This is important because many patients evaluated for LAAO are at high risk of bleeding. This study found that DOAC therapy is likely the best option for most patients because it prevents device-related thrombosis while being relatively safe. However, if DOAC therapy is not feasible, DAPT can also be used. It is unclear whether switching from DOAC therapy to DAPT or SAPT will reduce bleeding risk after LAAO placement.
Thank you for listening to this podcast, Why We Do What We Do in Cardiology. The information in this podcast is for general information only for medical professionals and is not intended to be a substitute for medical advice from a qualified healthcare professional. We hope you found this information helpful, and we look forward to seeing you on the next episode.